Welcome to the deep dive. Today, we're getting into a really vital area, pediatric health, specifically hematological and oncological disorders. Understanding these is, well, fundamental.
Absolutely. Think of this as a focused look to get you up to speed. We're
Hmm.
diving into Chapter 29 of Saunders Comprehensive Review for the NCLEX-PN Exam, 7th edition. It's packed with key concepts, assessment, interventions, safety, the works.
Right. Our mission is to break it all down, make it comprehensive, but, you know, easy to grasp. Whether you're studying or just curious, this should give you a solid base. Okay, let's start with sickle cell anemia,
Okay, so sickle cell anemia, it's what we call a hemoglobinopathy. Basically, a disorder where there's something wrong with the hemoglobin structure.
the oxygen carrier.
Exactly. In sickle cell, the normal adult hemoglobin A, gets replaced partially or sometimes completely by this abnormal type, sickle hemoglobin S.
And what's the root cause of that replacement? Is it genetic?
Yeah, it's genetic. It comes down to inheriting a gene that makes a different beta-globin chain for the hemoglobin molecule.
Okay. And who's most at risk?
The highest risk is for kids whose parents are both heterozygous for hemoglobin S, meaning they each carry one copy of the gene. It's also more common in people of African American descent.
How is it diagnosed?
Well, screening often starts with a sickle turbidity test. SickleDex is a common name. If that's positive, then they do a confirmatory test called hemoglobin electrophoresis. That one can tell the difference between sickle cell trait, just carrying the gene, and sickle cell disease, having both genes.
Got it. So you identify the hemoglobin S. What actually causes the problems, the sickling?
It's all about oxygen. Hemoglobin S is really sensitive to low oxygen levels. So when red blood cells release oxygen to the tissues, the hemoglobin S molecules can sort of clump together.
And that changes the cell shape.
Right. They go from being flexible discs to these rigid crescent or sickle shapes. And those sickled cells, they just don't flow well through tiny capillaries. They can clump up and will block the blood flow.
Ah, so the clinical picture we see stems from those blockages and maybe the red cells being destroyed faster too.
Precisely. Obstruction and increased red blood cell destruction, and certain things can trigger this sickling, leading to a sickle cell crisis.
Not what sort of things?
Things like fever, getting dehydrated, significant emotional or physical stress, infections, basically any situation that increases the body's oxygen demand or messes with oxygen transport. Think high altitudes, maybe?
Okay. And the chapter mentions different types of crises.
Yes, there are 4 main types described. The most common is vaso-occlusive crisis, that's the blockage one, causing pain, often severe pain fever, and swelling.
Okay.
Then there's splenic sequestration. This is serious. A lot of blood gets trapped in the spleen suddenly. It causes profound anemia, low blood volume, hypovolemia, and can even lead to shock.
Wow.
Hyperhemolytic crisis is when red blood cells break down much faster than usual, leads to worse anemia, jaundice, the yellowing.
Right.
And finally, aplastic crisis. That's when the bone marrow temporarily stops making red blood cells, often due to a virus like parvovirus B19, results in really severe anemia and pallor.
Once a cell sickles, it's just stuck like that forever.
Not always, especially early on. If you can restore oxygen levels and get the person hydrated, the sickling can reverse. But if it keeps happening, repeated sickling episodes can cause permanent damage. The cells stay sickled.
Which leads to long-term problems.
Exactly. That's why prevention is so key, avoiding infections, staying hydrated. And then treatment during a crisis focuses on, well, hydration, oxygen, managing pain, and rest. It really needs that team approach.
Right. Box 29-1 sums those crises up nicely. So during a crisis, what specific things are you assessing?
It depends on the crisis type, really. For vaso-occlusive, you're zeroing in on pain location, severity, also checking for fever, swelling. For splenic sequestration, you're looking for signs of severe, rapid anemia, extreme pallor, fatigue and signs of shock like fast heart rate, low BP, hyperhemolytic. You'd see worsening anemia, jaundice, maybe a high reticulocyte count on labs. And aplastic crisis, the big things are that sudden drop in hemoglobin and really noticeable pallor.
Makes sense. And interventions follow from that assessment. Hydration seems critical across the board.
Absolutely critical. Oral fluids, IV fluids, got to keep that blood flowing. Sometimes electrolyte replacement is needed too. And interestingly, good hydration actually helps with pain control.
And oxygen. Is that always used?
Often, yes. It helps increase oxygen saturation, which might prevent more cells from sickling, though it doesn't reverse the ones that already have. Blood transfusions might also be needed for severe anemia or sequestration.
What about pain management?
Crucial. The chapter stresses giving analgesics around the clock, not just PRN, to keep pain under control. And it specifically warns against using meperidine Demerol because of the seizure risk in these patients.
Good point about meperidine. Any tips for positioning?
Yeah, comfort and circulation are key. Keep extremities extended, avoid bending joints too much. Head of the bed usually not higher than 30 degrees. Avoid anything that puts strain on painful joints. And definitely no knee gatch on the bed that can block flow to the legs.
Gotcha. Diet.
High calorie, high protein, plus folic acid to help with red cell production. And because infection risk is high due to basically the spleen not working well, functional asplenia antibiotics might be given prophylactically, especially in younger kids.
What complications do you need to be really watchful for?
Worsening anemia, obviously.
Okay.
Signs of decreased perfusion, like changes in mental status, cool extremities, less urine output. And of course, shock, watching heart rate, blood pressure, consciousness level.
And education for the family sounds vital, too.
Oh, absolutely. They need to know the early signs of a crisis, how to prevent triggers like dehydration, and when to seek help immediately.
The chapter also mentions immunizations being extra important. Why is that?
Because of that functional asplenia we mentioned, the spleen normally filters out certain bacteria. Without that function, kids are super vulnerable to infections like pneumococcal and meningococcal disease. So sticking strictly to the vaccine schedule, including those specific ones and the annual flu shot, is critical.
Right. And sometimes a splenectomy might be needed.
For recurrent splenic sequestration, yes, removing the spleen might be considered. And finally, don't forget genetic counseling for the parents, helping them understand the hereditary side of things.
Okay, let's shift gears to iron deficiency anemia, another common one.
Very common. This happens when the body just doesn't have enough iron stored up. So there's less iron available to make hemoglobin for the red blood cells.
What usually causes that lack of iron in kids?
Several things. Maybe not getting enough iron in the diet, especially during growth spurts. Increased need, like in adolescence, blood loss, maybe chronic slow loss, or sometimes problems absorbing iron in the gut.
How this show up? What do you look for?
You might see pallor, that paleness in the skin, inside the mouth, nail beds. The child might be weak, tired, irritable. Labs would show low hemoglobin and hematocrit. And if you look at the red cells under a microscope, they'd be microcytic, smaller than normal, and hyperchromic, paler. Serum ferritin, which measures iron stores, would also be low.
So interventions are all about getting iron levels back up.
Pretty much. Increase iron intake. For infants, that often means iron-fortified formula. For older kids, it's about diet teaching about iron-rich foods like red meat, beans, fortified cereals. Chapter 11 has more on that.
And supplements.
Yes, iron supplements like ferrous sulfate are usually prescribed. If it's really severe or oral iron isn't working, they might need IM iron using the Z-Track method or even IV iron.
Are there special instructions for giving oral iron?
Oh yeah, several key points. It's best absorbed on an empty stomach, like between meals. But if it causes stomach upset, taking it with a little food is okay.
Okay.
Giving it with vitamin C, like orange juice, boosts absorption. But avoid giving it with milk or antacids. Those decrease absorption.
Good to know. Any side effects?
Yep. Parents should know stools might turn black or dark green, and constipation can happen. Also, liquid iron can stain teeth, so use a straw if possible, and brush teeth right after. And super important, keep it locked away. Iron overdose is really dangerous for kids.
Safety first. Okay, moving on to aplastic anemia. This sounds more serious, affecting all blood cells.
It is very serious. Aplastic anemia means the bone marrow basically fails, or is suppressed. So you get a deficiency of red cells, white cells, and platelets. That's called pancytopenia.
What causes the marrow to fail like that?
It can be congenital, something you're born with, that's primary, or it can be secondary, acquired later. Acquired causes can include exposure to certain toxins or drugs, myelotoxic agents, some viruses like hepatitis, radiation, or even autoimmune conditions where the body attacks its own marrow. Sometimes, though, the cause is just unknown.
How's it diagnosed for sure?
The key test is a bone marrow aspiration and biopsy. In aplastic anemia, you see very few blood-forming cells, and the marrow is mostly replaced by fat. It looks yellow instead of red.
As the goal of treatment?
To get the bone marrow working again. The best option, if possible, is a bone marrow transplant, especially if a matched donor is available. If not, or if it's less severe, they use immunosuppressive therapy to calm down the immune system if it's attacking the marrow. And obviously, if a drug is causing it, you stop the drug.
What signs and symptoms would you see with pancytopenia?
You see problems from low counts of everything. Low red cells mean anemia, pallor, fatigue, fast heart rate. Low platelets, thrombocytopenia mean bleeding risk. Petechiae, those little red spots, purpura or bruising. nosebleeds. Low white cells, leukopenia mean high infection risk, fevers, sore throats.
So nursing interventions cover all those bases.
Exactly. If a transplant is planned, you prep the child and family. You'll administer immunosuppressants like ATG or ALG, maybe colony-stimulating factors to boost cell production. Corticosteroids, cyclosporine might be used. Supportive care includes blood and platelet transfusions. And infection control is absolutely critical. Plus, advising parents about getting a medical alert bracelet is important.
Okay, let's talk about hemophilia, a bleeding disorder.
Right. Hemophilia is actually a group of inherited disorders where there's a deficiency in one of the specific proteins needed for blood clotting the coagulation factors.
Why is knowing the specific factor deficiency so important?
Because treatment is all about replacing that exact missing factor. If you don't give the right one, it won't work. And getting the right replacement helps prevent or treat bleeds, especially into joints, which can cause chronic damage over time.
What are the main types?
Hemophilia A is the most common. That's a factor VIII deficiency. Then there's hemophilia B, or Christmas disease, which is a factor IX deficiency.
How are these inherited?
They're typically X-linked recessive. The genes are on the X chromosome, so males who inherit the faulty gene from their mother will have the disease. Females are usually carriers. They have one faulty gene, but also a normal one on their other X chromosome, so they don't usually have severe symptoms, but they can pass it on.
Interesting. So treatment is factor replacement. Anything else?
Yes. Pain meds are often needed. Corticosteroids might be used for joint bleeds. For mild hemophilia A, there's a drug called DDAVP, desmopressin. It helps release stored factor VIII the body already has. Also, sometimes drugs called antifibrinolytics are used to help clots stabilize, especially for mouth or nosebleeds.
What signs might make you suspect hemophilia?
A history of abnormal bleeding, maybe after circumcision or Einer surgery. Frequent nosebleeds. The big one is bleeding into joints hemarthrosis, causing pain, swelling, warmth, limited movement. Easy bruising is common too. Lab tests for platelet function are normal, but specific factor assays showed the low factor VIII or IX level.
What are the key nursing actions for a child with hemophilia?
Preventing and managing bleeds is number one. Monitor closely for any bleeding, internal or external. Teach parents and eventually the child how to administer factor replacement, either prophylactically or when a bleed happens.
Okay.
If a joint bleed occurs, immobilize, elevate, apply ice. Watch neurological status carefully. Brain bleeds are rare but serious. Check urine for blood. For cuts, apply pressure for a good 15 minutes. Education is huge, recognizing bleeds, controlling them, knowing which activities are safe. No contact sports, but things like swimming are great. Protective gear for biking, skating, and definitely a medic alert bracelet.
Right. Let's touch on von Willebrand's disease, another bleeding disorder.
Yes, it's actually the most common inherited bleeding disorder. It's caused by a problem with von Willebrand factor, or VWF. Either there isn't enough of it or it doesn't work properly.
And what does VWF normally do?
It has two main jobs. First, it helps platelets stick to the site of a blood vessel injury. Second, it acts like a bodyguard for factor VIII in the blood, protecting it from breaking down too quickly.
So what kind of bleeding symptoms do you see with VWD?
Because it affects platelet function and factor VIII, people tend to bleed more from mucous membranes, so frequent nosebleeds, easy bruising, bleeding gums, prolonged bleeding after cuts or dental work. Heavy menstrual periods in girls are common too. Joint bleeds are less common than in hemophilia, but can happen.
How is it managed?
It depends on the type and severity. DDAVP can work for some types, as it releases stored VWF. For more severe bleeding, they use plasma-derived concentrates that contain both VWF and factor VIII. Antifibrinolytics can help with mucosal bleeding. And like hemophilia, emotional support and a medic alert bracelet are important.
Okay. Now for β-thalassemia major, sometimes called Cooley's anemia, box 29-2 talks about different types, but we'll focus on the major form.
Right. Β-thalassemia major is a severe inherited disorder where the body produces very little or no beta-globin, which is part of hemoglobin. It's autosomal recessive need to inherit the faulty gene from both parents. It's more common in people of Mediterranean, Middle Eastern, and Asian descent.
What happens when you don't make enough beta-globin?
You get severe chronic anemia, usually showing up in the first year. The body tries hard to make more red cells, but they're defective. This leads to bone marrow expanding and other issues.
What kind of physical signs might you see?
The chronic anemia and the body's attempts to compensate cause characteristic changes. Bone marrow expansion can lead to skeletal changes like a prominent forehead frontal bossing and overgrowth of the upper jaw. They might have wide-set eyes, a flattened nose. Skin can look pale, maybe even greenish yellow from red cell breakdown and iron overload. The liver and spleen often get enlarged to hepatosplenomegaly. Labs show severe anemia, microcytic hypochromic red cells.
How is this treated? It sounds like managing the anemia is key.
It is. The main treatment is lifelong regular blood transfusions, maybe every few weeks, to keep hemoglobin levels up. This prevents severe anemia complications and suppresses the body's ineffective red cell production.
Is there a cure?
The only cure is a hematopoietic stem cell transplant, a bone marrow transplant, but that requires a matched donor and isn't suitable for everyone. Sometimes, if the spleen gets very large and destroys too many red cells, a splenectomy might be done, but that increases infection risk.
You mentioned iron overload. Is that from the transfusions?
Exactly. All those transfusions load the body with iron, and we don't have a good way to get rid of excess iron naturally. It builds up in organs like the heart and liver and causes damage. So chelation therapy is absolutely essential.
Chelation.
Yeah, using medications that bind to iron so the body can excrete it. Drugs like deferoxamine, which is usually given as an infusion under the skin, or oral meds like deferocerox or deferoprone, they have to monitor iron levels closely to adjust the chelation.
If they have a splenectomy, what are the key points afterwards?
Big focus on infection prevention. They need to know the signs of infection and seek help immediately, often need prophylactic antibiotics. And they must be up to date on all vaccines, especially pneumococcal, meningococcal, and flu shots, because the infection risk is much higher without a spleen. Genetic counseling is also important for these families.
Okay, now we're shifting into childhood cancers, starting with leukemia. Chapter 41 has more detail too.
Right. Leukemia is cancer of the bone marrow. It involves a malignant, uncontrolled increase in immature white blood cells called blasts. These blasts crowd out the normal cells in the marrow.
So that leads to problems with red cells, normal white cells, and platelets.
Exactly. You get anemia from low red cells, increased infection risk from low normal white cells, neutropenia, and bleeding risk from low platelets, thrombocytopenia.
What causes leukemia in kids? Is it known?
The exact cause usually isn't known. It seems to be a mix of genetic and maybe environmental factors leading to genetic damage in a single marrow cell, which then multiplies uncontrollably.
Any known risk factors?
Some genetic conditions like Down syndrome increase risk, high-dose radiation exposure, certain chemical exposures, maybe some viruses, previous chemotherapy for other cancers. But for most kids, there's no identifiable cause.
What's the most common type?
Acute lymphocytic leukemia, AL. That accounts for about 75% of childhood leukemias. It involves immature lymphocytes. It peaks around ages 2 to 5, slightly more common in boys.
What signs and symptoms might point towards leukemia? They sound like they could be vague initially.
They can be. Symptoms come from the marrow being infiltrated and normal cell production being down. So things like fever, fatigue, weakness, pallor from anemia, easy bruising or bleeding from low platelets, bone or joint pain because the marrow is packed with leukemia cells, swollen lymph nodes, maybe an enlarged liver or spleen, sometimes loss of appetite, weight loss. If it spreads to the central nervous system, you might see headaches or vomiting.
Boxes 29 to 3 and 29 to 4 highlight infection and bleeding risks. What are the nursing priorities there?
Huge priorities for infection. Meticulous hand hygiene, avoiding sick contacts, maybe protective isolation if counts are very low. Monitor constantly for fever or any sign of infection. Get cultures, start antibiotics quickly if ordered for bleeding. Gentle handling, soft toothbrush. Avoid rectal temps or suppositories. Minimize injections, apply pressure longer. Watch for any bruising, petechiae, nosebleeds. Platelet transfusions might be needed.
Fatigue and nutrition are big issues too, right?
Definitely. Fatigue is huge. Need to balance activity and rest, cluster care. Nutrition can be tough with nausea, mouth sores, poor appetite from the disease and treatment. Small, frequent meals, maybe supplements, sometimes tube feeding or IV nutrition is necessary.
And chemotherapy is the main treatment. What are the nursing implications?
Yes, chemo is central. It's usually complex, multi-drug regimens over a long time. Nurses manage administration, monitor side effects. A key thing is monitoring for bone marrow suppression, especially the point of lowest blood counts after chemo. That's when infection and bleeding risks are highest.
Besides infection and bleeding, what other chemo side effects need management?
Nausea and vomiting need antiemetics. Mouth sores or mucositis need careful oral hygiene, maybe pain relief rinses. Diarrhea or constipation. Hair loss, alopecia, prepare the family, it usually grows back. Fatigue, changes in appetite. Need to monitor hydration. Watch for things like hemorrhagic cystitis, bladder irritation, peripheral neuropathy. Educate parents on when to call the doctor. If they have a central line, meticulous care is vital. And of course, lots of emotional support.
Okay, let's discuss Hodgkin's disease next, a type of lymphoma.
Yes. Hodgkin's lymphoma. It's a cancer of the lymphatic system, specifically characterized by the presence of Reed-Sternberg cells, which are large, abnormal lymphocytes found in the lymph nodes. It usually starts in one node or chain and spreads predictably to nearby nodes, and sometimes other organs like the spleen or liver.
What's the typical age group and any risk factors?
It has two peaks, one in late adolescence, young adulthood, which is relevant for pediatrics, and another later in life. The cause isn't certain, but links to Epstein-Barr virus, EBV, and maybe previous exposure to certain chemo drugs have been suggested.
What's the outlook like for kids with Hodgkin's?
Generally, it's very good. High cure rates, especially in earlier stages. Prognosis depends on the stage and response to treatment.
How was it treated?
Mainstays are radiation and chemotherapy, either alone or combined, depending on the stage and risk factors. The goal is cure while minimizing long-term side effects.
What are the common signs when it presents?
Most often, painless swelling of lymph nodes, usually in the neck, armpit, or groin. They feel firm, rubbery, movable. Sometimes a node above the collarbone is the first sign. If nodes in the chest are enlarged, it might cause a cough or shortness of breath. Some kids have systemic B symptoms. Unexplained fever, weight loss, drenching night sweats. Itchy skin, pruritus can also occur. Diagnosis needs a lymph node biopsy showing those Reed-Sternberg cells. Staging involves imaging and sometimes a bone marrow biopsy.
What are the key nursing roles during treatment?
Managing side effects of chemo and radiation is big. Monitoring for bone marrow suppression infection, bleeding risk. Managing fatigue, nausea, vomiting. Skin care if they're getting radiation. Providing emotional support. Educating about potential long-term effects.
All right, let's move to neuroblastoma, or Wilms tumor, a kidney tumor.
Exactly. It's the most common kidney cancer in children. Usually affects just one kidney, but can be bilateral sometimes. It can metastasize, often to the lungs.
What age does it usually appear, and are there risk factors?
Peak age is around 2 to 3 years old. It's linked to certain genetic syndromes and congenital anomalies like Wagner syndrome or Beckwith-Wiedemann. Sometimes there's a family history.
How is Wilms tumor treated?
Usually a combination approach. Surgery is key, removing the affected kidney, called a nephrectomy, plus chemotherapy and sometimes radiation, depending on the stage and tumor characteristics.
What signs might suggest a Wilms tumor?
The most common sign is an abdominal mass or swelling, usually felt by a parent. It's typically firm, smooth, and doesn't cross the midline. Other signs might include abdominal pain, blood in the urine, hematuria, high blood pressure, hypertension, because the tumor can secrete renin, sometimes fever, weight loss, or anemia symptoms if there's bleeding within the tumor. If it spreads to the lungs, maybe shortness of breath.
There's a really important warning about not palpating the abdomen if Wilms is suspected. Why?
Yes, absolutely critical. The tumor often has a thin capsule around it. Palpating the abdomen could rupture that capsule and spill tumor cells into the abdominal cavity, worsening the stage and prognosis. So, once suspected, an unnecessary abdominal palpation, put a sign up: do not palpate abdomen. Pre-op care involves monitoring blood pressure closely and measuring abdominal girth daily.
What about after surgery, key post-op interventions?
Monitor vital signs, especially BP and temperature. Watch for bleeding or infection at the surgical site. Keep strict track of intake and output to check function of the remaining kidney. Listen for bowel sounds. Watch for distension, risk of ileus, pain management. And they'll likely get chemo, so managing those side effects too.
Okay, next up is neuroblastoma.
Neuroblastoma is a tumor that arises from primitive nerve cells, the neural crest cells. It often starts in the adrenal gland on top of the kidney or in the sympathetic nerve tissue along the spine in the abdomen, chest, or neck. It's the most common solid tumor outside the brain in childhood.
What age group and what's its behavior like?
Most are diagnosed before age 5. Unfortunately, it's often an aggressive tumor and frequently has already metastasized by the time it's diagnosed. Common sites for spread are bone marrow, bone, lymph nodes, liver, skin. Prognosis is quite variable. Younger age at diagnosis is generally better.
How is it diagnosed and treated?
Diagnosis involves finding the tumor with imaging like CT or MRI, checking urine and blood for tumor markers called catecholamines, and doing scans like IBG that neuroblastoma cells specifically take up. Biopsy confirms the diagnosis. Treatment depends heavily on stage, and risk factors could involve surgery, chemo, radiation. High-risk neuroblastoma often gets very intensive treatment, including high-dose chemo with stem cell transplant.
Because it can start in different places, the symptoms must vary a lot.
Hugely variable. An abdominal tumor might present as a hard, irregular mass, maybe crossing the midline, causing constipation or urinary issues. A chest tumor could cause breathing problems, bone pain if it's spread to bones. Metastasis around the eyes can cause bruising, raccoon eyes, and bulging eyes, exophthalmos. General signs like fever, weight loss, irritability are common. Sometimes spinal cord compression can cause paralysis.
What are the nursing considerations before and after surgery?
Pre-op. Monitor symptoms based on tumor location. Provide lots of emotional support. Post-op. Monitor for complications specific to the surgical site. Manage chemoradiation side effects. A big part is supporting the parents, who often feel guilt or distress, especially if diagnosis was delayed. Connecting them with resources is important.
Let's discuss osteosarcoma or osteogenic sarcoma, bone cancer.
Yes, the most common primary bone cancer in kids and teens. It develops from bone-forming cells, usually in the metaphysis, the growing end of long bones. Most common sites are around the knee distal femur or proximal tibia, or in the upper arm bone, the humerus.
What age is typical? Any factors?
Peak is during the adolescent growth spurt, ages 10 to 25, slightly more common in boys. Risk factors include prior radiation, some rare genetic syndromes, but usually it's sporadic.
How is osteosarcoma treated?
It's usually chemotherapy combined with surgery. Chemo is given both before surgery, neoadjuvant, to shrink the tumor and kill any spread, and after surgery, adjuvant. Surgery aims to remove the tumor completely, either through limb salvage surgery, replacing the bone with a prosthesis or graft, or, if necessary, amputation.
What symptoms usually bring kids in?
Pain at the tumor site is the most common symptom. It might start mild and intermittent, often blamed on injury or growing pains, but it usually becomes constant and worse, especially at night. There might be a palpable mass or swelling, limping if it's in the leg, maybe limited motion. Sometimes a fracture through the weakened bone, pathological fracture, is the first sign.
What are the nursing priorities for these kids?
Preparing them and the family for intense treatment, chemo, and major surgery, lots of honest communication and support. If amputation is planned, preparing them for that, prosthetic fitting, rehab. Body image is a huge issue, especially for teens. And educating them about phantom limb pain if they have an amputation, that sensation of pain or itching where the limb used to be. Pain management throughout is key.
Okay, finally, brain tumors. The chapter notes infratentorial are most common in kids.
Right. Infratentorial means below the tentorium cerebelli, in the back part of the brain, the cerebellum and brainstem area. These often cause symptoms from increased intracranial pressure, or ICP, because they block the flow of cerebrospinal fluid or affect coordination controlled by the cerebellum. Supratentorial tumors in the main part of the cerebrum are less common in kids.
What are the typical signs and symptoms?
Highly variable depending on location, size, age, but common things include headache, often worse on waking up, vomiting, sometimes projectile, often without nausea, changes in behavior, mood, personality, clumsiness, balance problems, difficulty walking, maybe vision changes like double vision or seizures. In infants, a bulging fontanelle. Signs of increased ICP are crucial to spot. Box 29-5 lists these, but think headache, vomiting, lethargy, irritability.
What's key for nursing care before brain surgery?
Close neurological monitoring is a vital level of consciousness, pupils, strength. Seizure precautions. Monitor nutrition and weight. Prepare them for head shaving if needed. Offer a hat. Explain about the head dressing they'll have after surgery.
And after surgery, what are the big post-op concerns?
Again, constant neurochecks. Monitor vital signs very closely, especially temperature surgery near the hypothalamus can mess with temp regulation. Watch for respiratory problems, signs of meningitis like stiff neck. Monitor for increased ICP or bleeding. Check the dressing for drainage, especially clear CSF leakage or blood pooling behind the head.
CSF leakage.
Yes, clear drainage from the nose, ears, or incision could be cerebrospinal fluid. It needs to be tested for glucose and reported immediately. Any sluggish or unequal pupils are an emergency sign to potential herniation. Follow positioning orders carefully. Manage fluids meticulously to avoid overload. Prevent vomiting. Keep the environment quiet. Pain control. And lots of support.
The chapter wraps up with a critical thinking question about hemophilia after a car crash, highlighting bleeding precautions. And then those practice questions with rationales.
Yeah, those questions are really good for checking, understanding, and seeing how these concepts apply in scenarios. It reinforces why knowing this stuff matters.
Absolutely. Well, that covers our deep dive into Chapter 29 of Saunders, focusing on pediatric hematology and oncology. We've hit sickle cell, various anemias, bleeding disorders like hemophilia and VWD, thalassemia, and then the major childhood cancers, leukemia, lymphoma, Wilms's tumor, neuroblastoma, osteosarcoma, and brain tumors.
We really covered a lot of ground. The assessment points, the interventions, the rationales. Hopefully, this gives you a solid framework for understanding these complex conditions. They really require specialized knowledge and careful nursing care.
Definitely. It's a reminder of the complexity of these diseases, the genetics, the physiology, and the huge impact on kids and families. Nursing plays such a critical role in supporting them through diagnosis, treatment, and everything that comes after. We hope this discussion helps solidify that understanding. With that, we've covered the content from Chapter 29.